Pleasant good evening to you all online. Welcome to tonight's webinar, Let's Rethink Diabetes. Thank you for joining us tonight for a different kind of kickoff. My name is Dr. Kendra Lee, Medical Manager here at Dr. Reddy's Laboratories, Jamaica. Tonight, we're joined by two exceptional voices in endocrinology, and I will welcome them shortly. Just some ground rules for tonight. Of course, we'll be having our survey at the end. We will be welcoming all questions, all comments during. Please feel free to use our chat function to submit your questions, and then we'll respond to them during the section. Of course, if any concerns, please do raise them in the chat as well, and we openly invite you to engage with our speakers this evening. With that said, our topic for this evening, we'll be looking at diabetes. As we know, diabetes and obesity are major problems within the Caribbean. And of course, we have to rethink how we address them in order to properly manage this for patients. Our first speaker this evening will help us to do so. We have Dr. Patrice Francis Emmanuel, consultant endocrinologist at the University of the West Indies Hospital. She's also known for being in many publications which involve endocrinology specialties, looking at different factors such as cardiometabolic risk in conditions such as marasmus and kwashiorkor. She's also looked at artificial intelligence and the incentives for this in strengthening the behavioral approaches for type 2 diabetes, and many other manuscripts that we would have looked at as well. So for tonight's conversation, we openly welcome her to take us through our first topic on holistic cardio-renal metabolic risk and how we can manage this in type 2 diabetes. The virtual floor is yours, Dr. Emmanuel.
Thank you so much, Dr. Kendra. And good afternoon, everyone. Thank you for joining us. I am a little hoarse, so I'm really hoping that my voice will hold up for the next hour. And over that period, we will be speaking about holistic cardio-kidney metabolic care in modern management of type 2 diabetes. And this is something that we've been hearing a lot about for the last year or so, and that will be a part of our approach to seeing patients with diabetes ongoing. So for the next few minutes or during the presentation, we're hoping to achieve these objectives. We want to look at establishing the CKD or the CKM interplay, cardiac kidney metabolic, cardiac renal metabolic, some would say. We want to review some pathophysiology, review global prevalence and impact of some of the components of the cardiac kidney metabolic syndrome, discuss screening in patients along the spectrum, and then we'll review management options. So the cardio-kidney metabolic syndrome, otherwise called the cardio-renal metabolic syndrome, is quite a complex, interconnected state or spectrum. It doesn't entail a single disease entity, but there is a significant interplay between cardiometabolic risk factors and how they intersect with chronic kidney disease. So we recognize the entity as a triple threat, and a triple threat partnership at that, involving the heart, the kidney, and the metabolic system. And we'll speak a little bit more in depth about all of these as we move along. But the crux of what we're speaking about and what a lot of the discussion will be surrounding is that of diabetes within the spectrum. And there's a typo, should be in the cardio-kidney metabolic spectrum, the CKM spectrum. We know that in our patients with diabetes, they do have quite a significant elevation in their cardiovascular risk. They do have a higher tendency to have cardiovascular complications compared to similar patients without diabetes. And in this population, we tend to have the cardiovascular risk factors clustering. So the hypertension, obesity, chronic kidney disease, and dyslipidemia usually go hand in hand within our patients who have diabetes. And this is a nice chart which shows two cycles which very often go hand in hand. To the left, we're seeing obesity, and we know of the new definition for obesity and the new approach to looking at obesity, but irrespective, individuals with obesity tend to have a lot of ectopic fat. So we have fat deposited in visceral organs like the liver, within the pancreas as well. And this drives significant insulin resistance, which sets the stage for the development of type 2 diabetes. And then on the other spectrum, we see where diabetes and uncontrolled prolonged hyperglycemia results in downstream effects, which cause chronic kidney disease, which may entail a reduction in estimated GFR, coupled with albuminuria. And of course, there is an interplay as well with cardiovascular disease. It's atherosclerotic and other cardiovascular components. So this is really just showing how intertwined all of this is. Comorbidities among patients with diabetes, including hypertension, diabetes, obesity, causing lots of inflammatory changes, what we tend to call glucolipotoxicity, and several microvascular and macrovascular abnormalities which drive cardiovascular disease. There is an element of remodeling in individuals who may not even have atherosclerotic cardiovascular disease. We may see dysfunction of the heart muscle and heart failure, whether it's with reduced or preserved ejection fraction. And this driving hypoperfusion to the kidneys, resulting in CKD, among other pathophysiologic processes. So all in all, very high glucose levels over a long period of time results in a lot of complicated changes cellularly, which results in changes in the heart, whether it's in the blood vessels supplying the muscles or within the muscles themselves, what we typically call diabetic cardiomyopathy, increasing the likelihood of symptomatic heart failure. One of the big components of the CKM spectrum is chronic kidney disease, and we do know that quite a lot of work has been done on prevalence and risk factors for both acute and chronic kidney injury in Jamaica and other territories in the Caribbean. But we know that on a larger global spectrum as well, the burden of chronic kidney disease is very high, and we're seeing where high blood sugar is a huge driver. The biggest driver, if you were to look across all age spectrums globally, and this was a paper published in The Lancet in 2025, and this results in significant loss of productive years, because we're seeing a lot of this happening in the age group where people are typically most productive. Obesity, a similar thing. Locally, almost 50% of our adult population is either overweight or obese, and we're seeing the global trends here as well, with billions of people worldwide being affected by obesity. But why is the cardio-kidney-metabolic syndrome so important? Because we know of the importance of all the entities, but when you put everything together, we recognize that it's associated with significant reduction in life expectancy. So as we move through the stages where people are thought to be normal with no risk factors, they may have some element of excess adiposity. They move on to developing diabetes to the point where they have impairment in kidney function with albuminuria falling in eGFR. And later on, cardiovascular manifestations, we're seeing that the more components of the CKM that one accumulates, the higher the mortality. So it's very significant for us to be able to recognize the components early and to try to address, to mitigate poor outcomes. So how do we propose to identify the cardio-kidney-metabolic syndrome in our clinical practice? It sounds like a very complicated sounding term, but when you pick it through and look at the individual components, it perhaps is not as daunting. So one of the first things we want to look at is when our patients come in to see us, we want to assess whether they are at ideal weight. And this is a very difficult to discuss topic sometimes, because we have a tendency to depend on weight and height and body mass index to categorize individuals as being obese or overweight. That might not be the most accurate thing. Anthropometry is very easily available. If you have a tape measure and a stadiometer, you can measure waist circumference, check waist to hip ratio, waist to height. And that may actually give you sometimes a better sort of proxy to overweight or obesity than the body mass index, which might be elevated in individuals who are muscular and who may not even have a lot of ectopic fat to begin with. The imaging tools, ideally, but BIA, your DEXA scans, and other abdominal imaging tools, not routinely used per se to assess for obesity, but very often we get ultrasound reports coming back to say there's hepatic steatosis, and a lot of times persons don't really pay much attention to it, but I put it to you that that is very important to recognize and to try to address. We speak about ectopic fat a lot, and we are very aware as well that ectopic fat is very metabolically active. So individuals who have a lot of fat deposited within their visceral organs, like their liver, will in turn have increased insulin resistance, and they will have a higher level of inflammation. Lots of inflammatory changes taking place that result in significant cardiovascular untoward effects compared to individuals who might be of a similar body mass index, mind you, but they have less visceral fat and most of their fat is actually subcutaneous, which is less metabolically active. It's very important to make the distinction between visceral and subcutaneous fat and to understand the implications when it comes to inflammation and inflammatory changes. So fat deposited in the liver is very important to recognize, because we know that when fat lodges in the liver, it might promote hepatic inflammatory changes that result in what we call steatohepatitis. And if that is present for a prolonged period and is left unchecked and unaddressed, then these changes may actually result in the presence of fibrosis, and we know that that's a risk factor for cirrhosis and hepatocellular carcinoma. So it's not just the alcohol intake, it's not just the chronic hepatitis B and C that increase the risk of cirrhosis and hepatocellular carcinoma, but also chronic inflammatory changes from deposited fat. Once we recognize that, so you're in your office, you sent for an ultrasound for something not related, it comes back saying liver fat is present. We always want to know whether there is any suggestion that there might be fibrotic changes, because we know that this sets the stage for the development of cirrhosis later on. And it is very easy now to request an AST and ALT with a complete blood count, and inputting this information into a simple calculator that's easy to find online. You just enter the patient's age, their AST and ALT with a platelet count, and it will give you a score that we call a FIB-4 score, which is a marker somewhat of hepatic fibrosis. And this, though it might not be, it's not diagnostic, this might indicate to you which patients are at higher risk of the presence of fibrosis and those who you might need to send on for further gastroenterological investigations like the FibroScan. We know of the increased risk of cardiovascular disease among patients with type 2 diabetes as well, but the question is always, who do we screen and how do we screen? And this, according to the most recent published guidelines by the ADA, Standards of Care, really 2024, which said the same. Routine screening for patients who are not symptomatic, even though we know of the increased risk if they have no symptoms, and there's no evidence that sending patients for routine screening is something that should be done. But certainly if they have signs or symptoms of cardiac disease, or if you've seen an ECG that shows abnormalities, then these are individuals who should have further cardiovascular assessments done. But what has been included in what the guidelines are pushing now is that once you have a patient who has type 2 diabetes, you should actually start looking for features of subclinical or asymptomatic heart failure. And one of the tests that they suggest be done is the BNP. If the BNP is positive, then you can suggest that the patient has an echocardiogram. But the bottom line from this slide is patients who are asymptomatic do not necessarily need to be sent for an echocardiogram. But if you do the BNP and it's positive, then it's something to be looked into. And of course, we know of peripheral arterial disease, which patients with diabetes are at higher risk for. Individuals should be screened accordingly. And the least expensive or the easiest test to do is an in-office test, the ankle brachial index, and you can just do a brachial blood pressure on the leg, do the ratio, and with a ratio of 0.9 or lower, then the suggestion of peripheral arterial disease is present. Of course, it's not a highly specific test because you may have individuals who have normal range readings who actually have clinical peripheral arterial disease. We speak a lot about cardiovascular risk scores, and this has been a sour topic because the question is always, how do we extrapolate or utilize some of these scoring systems within our local population? Some of these scoring systems may not be fully applicable, and they may either underestimate or overestimate cardiovascular risk. And over the years, we've had quite a number of, combinations, permutations, adjustments to these scores to reduce the risk of bias and so forth. We know that there are changing risk factors, people with increasing BMI, less cigarette smoking, and so on, and they're changing trends in cardiovascular outcomes. But over the last couple of years, we have been introduced to what is called the Prevent ACVD risk calculator, which for most of us was quite a refreshing thing when we recognized that they removed some of the inherent biases that were present in some previous risk calculating tools, for instance, RACE. So for the Prevent score, ACVD score, which again is available free online, there are some of the inherent biases which were included in or present in previous or other calculators which are no longer present, but it's still not perfect. It does the risk changes depending on missing information, and sometimes the missing information is some of the standards or the social determinants of health, which resulted in these unavailable scores. So not everybody is able to do all the tests that are required to ensure that when you put them in, you get an accurate score. So again, there are some biases in it, but perhaps some improvement compared to others. But when you use the Prevent score, you're able to calculate a 10-year and a 30-year total cardiovascular risk for your patients. And it actually breaks it down into the subcomponents. So the risk for atherosclerotic cardiovascular disease versus heart failure, coronary artery disease, and stroke. So you can actually separate them so the patients can see some numbers, and you can use those figures to try and discuss. And if there are improvements in their risk scores and recalculations of the Prevent score, you can have the patient see the numbers and see whether there's improvement or not. So it kind of helps in that regard. But like I said, it's not perfect. How do we detect kidney disease? All of our patients, or a lot of our patients, do executive tests every year they do the executive test, and they'll have the urea and creatinine done. They will have their estimated GFR documented. But in our patients with diabetes, we want to ensure that physicians remember to request urine microalbumin/albumin to creatinine ratio, because a lot of times we are fooled by the presence of a normal, quote unquote, estimated GFR, not recognizing that there's significant albuminuria for which there is evidence-based care available, which can reverse and improve kidney disease. So it's imperative that we have our patients do tests to assess for the presence of albuminuria at least yearly and treat it accordingly, which we'll speak about soon. So the question is, how do we manage diabetes within the cardiac kidney metabolic spectrum? And we are very commonly caught focusing on glycemia alone. So individuals come in for care, they have diabetes, we're asking about the sugar readings, we're checking A1C, which is very good because ensuring that the A1C is at target is one of the ways in preventing progression and preserving beta cell function. and also reducing the risk of developing chronic complications. But we know that glucose control is not everything, and we need to make sure we see the patients in a holistic manner and identify where on the CKM spectrum they fall. Do they have overweight or obesity? Is there any evidence of clinical cardiovascular disease? Do they have angina symptoms? Do they have heart failure symptoms? Is there any evidence of albuminuria? And place them accordingly on the spectrum, and then ensure that the treatment options that are made available to them are those which will make a difference mortality and morbidity wise. It's significant, it's important that we address all the components of the spectrum simultaneously. So we don't just strive to achieve an A1C, which is at target, and forgetting that the weight needs to be managed. And there are agents which can be utilized to address the diabetes control while at the same time improving weight and addressing the obesity component, which Dr. Chin-Harty will speak much more about later on. So it's important that we emphasize that care of these patients with diabetes on the CKM spectrum is an interdisciplinary one. We need to recognize the presence or the availability of interdisciplinary care models. And it's always very important to have a point person as a care coordinator, depending on what your particular situation is, whether you're working in a health center, whether you're working in a hospital referral center, and sometimes in group practices. Having a coordinator at the center of it is ideal to make sure that all the moving parts are pulled together. And of course, always emphasizing the need for guideline-directed medical therapy. So we need to be kept abreast of what is guideline-directed and make sure that we offer this to our patients. The crux of the matter is that we always start and end with lifestyle management, lifestyle and risk management. The lifestyle aspect of care is a cornerstone pretty much. No matter where on the spectrum you fall, on the CKM spectrum, lifestyle adjustments are going to be very relevant and very important in ensuring better outcomes. So we hear this all the time, but we'll keep saying it. We want increase in physical activity. Not everybody is going to be able to get up to the 150 to 180 minutes of moderate exercise or 75 minutes of rigorous every week at the get-go, but they can start where they can, 10 minutes a day, and then once their exercise tolerance improves, then they can increase that over time. And of course, don't forget the strength training, which we're suggesting at least twice a week. And again, that will come out in very likely in the discussions when we speak about some other agents with which Dr. Chin-Harty will be going through in greater depth. We want to make sure that appropriate dietary changes are made, the DASH diet to reduce salt intake, increase in vegetable and grain consumption in our Mediterranean diet, and of course, reducing carbohydrate portions for those who have a need for weight reduction. So if your weight is within, the stipulated number or your body mass index, if that's what we're using, or if you think your weight is at target, then a weight reduction is not what we want. We want weight maintenance. But certainly in individuals who are overweight to obese, by whatever standards you're using, we want to set a target, reduce carbohydrate intake, and give them a number to go with. So I like to calculate it for the patients. They come in at 160 pounds. I would like a 5 to 10% weight loss over 3 to 6 months. I work it out and I tell them how many pounds I would ideally want. And that would work out to be like 2 pounds a month sometimes, or not an exorbitant number, because sometimes patients may think they need to drop 30 pounds in 3 months. It has to be realistic and sustainable. And sometimes if you give them a number that sounds reasonable, at 10 pounds over 3 months, it sounds better than they're thinking they need to go down to normal before they come back to see you. We need to encourage smoking cessation, reduction of alcohol consumption, all of the good habits that we want for optimal health. So for obesity, I alluded to this before, there is a change to the thinking of the approach to obesity and its diagnosis. There are individuals who may have quote unquote increased body mass index. They have no hypertension, their cholesterol is perfect, their blood sugar levels are fine, they don't have diabetes, there's no evidence of dysmetabolism, they have excellent exercise tolerance. These individuals would be considered to be preclinical, as opposed to those with a similar BMI or, weight sort of number in kilograms for the same height. But on the clinical side, these patients have comorbidities. They have hypertension, they have obstructive sleep apnea, they have osteoarthritis, they have cardiovascular disease. These are individuals who are considered to have clinical obesity. So I think that there is a change towards the thinking of how we label individuals as having diabetes, and a distinction to be made now between those who are preclinical, meaning they're healthy obese, quote unquote, versus those who have manifestations of the obesity. And traditionally, we say the approach to management is diet and exercise, but yes, these are very important and have to be a part of the approach, but very often patients are not able to get to their target because yes, lifestyle drives a lot of obesity, but we also know that there's a big genetic component. There's several genes out there which are important or involved in the development of obesity, up to 25 to 80%, depending on which paper you're looking at. So the focus, yes, needs to be on adjustment in lifestyle, but also offering patients pharmacotherapy, which is FDA approved and able to assist in the management of overweight and obesity. And we know of several of them, some oral, some injectables, and I won't steal Dr. Chinharty's thunder. She's going to be talking much more about those soon. I will just look at this very briefly, the role of weight control in the management of type 2 diabetes. There was some perspectives on semaglutide. And we know that these drugs work. They are GLP-1 receptor agonists. They work to reduce hunger at the level of the brain. They increase satiety or the feeling of fullness. But they do also have quite a significant number of other effects in the heart, in the kidneys, and generally in the body in terms of glycaemic control, in the skeletal muscle, in the liver to reduce liver fat, which we spoke about. And so while, yes, we're seeing weight loss, which for some people may be seen as cosmetic, it does have a holistic way of approaching management of individuals who have diabetes and maybe having issues with maintenance of target weights. In addition to the GLP-1 receptor agonists like semaglutide, we also have the combination GLP-1 GIP receptor agonists, which act on two receptors. Tirzepatide is the generic name, and we now have retatrutide, which is a triple agonist. They as well result in significant weight loss, but as a component of the weight loss, we do know that there's some muscle mass loss. And so individuals who are utilizing these agents need to recognize that, yes, you're losing weight. Some of it may not be just fat. Lots of muscle sometimes can be lost. So ensuring you have enough protein consumption and also that you do strength training exercises is very important in helping to preserve some of this muscle that would have ordinarily otherwise been lost. Right. So mindful of the time, we're looking at blood pressure as a component, as one of the risk factors, which is very intertwined in the whole CKM spectrum. All of the patients who come to see you, I would say whether they have diabetes or not, should have their blood pressure measured at every encounter. And certainly for your patients with diabetes, blood pressure measured at every encounter. And on average, if you have 2 or more readings with a number of more than 130/80, it should be considered a diagnosis of hypertension. Of course, this is blood pressure done in a correct manner, and this AHA instruction sheet can be found very easily online. It's difficult to read here, but very important that you follow the protocol for measuring the blood pressure properly, so that the results are most accurate. Of course, we know that some patients will have elevation in blood pressure in the clinic setting, which are normal at home. And if you have a high enough index of suspicion, that this patient may actually be normotensive, you can send for ambulatory blood pressure monitoring just to confirm or refute your diagnosis of hypertension to avoid treating patients who may not necessarily have the diagnosis. But not everybody will be able to have an ABPM done or ambulatory blood pressure monitoring. So ensuring you do the blood pressure in the correct, using the correct protocol is very important. Standards of care again for diabetes comes out every year. This was a 2025 algorithm for the management of hypertension in individuals who are non-pregnant and have diabetes. And we documented that, yes, over 130/80, we start with one agent as long as the blood pressure is less than 150/90. But if when the patients come in, their blood pressures are quite elevated, then a single agent is unlikely to control them. And we wanted to start with dual therapy very early. And that was the crux of what I wanted to say from this slide. So at 2 agents, if the blood pressure is elevated. Lipid management, very, very important in the holistic management of individuals who have diabetes. At diagnosis of type 2 diabetes, we should always document our lipid levels, and we need to repeat if we're initiating anti-cholesterol or low cholesterol lowering medications. We want to repeat the test within 4 to 12 weeks of initiating, or within 4 to 12 weeks of making an adjustment, just to make sure you're achieving the targets. And we'll speak more about specific targets. But what are the goals of lipid management in individuals with cardio-kidney-metabolic syndrome? Very often, and I like to speak from experience, and I know that a lot of people who are online may be able to relate to it. The patients will have their executives, they come to you, and their LDL level is 2.2 millimoles per liter, which mark you on the form or on the lab report is said to be normal. But the patient who has type 2 diabetes will not be the patient for whom I'm using the reference ranges that are sent through on the form from the lab, because we know that type 2 diabetes significantly accelerates atherosclerosis. There's a lot of chronic inflammation that's going on. And so while we're using the LDL and the cholesterol and triglyceride levels as a guide on certainly how to adjust our medications, we want to let the patients know that we're not just treating to a number, okay? We want to ensure statins are on board to result in lipid management, which results in a reduction in chronic inflammation. We know of the pleiotropic effects, the anti-inflammatory effects of statins, and the overall several studies which show significant cardiovascular risk reduction in individuals with type 2 diabetes placed on statins. So this is a primary preventative measure that our patients should understand needs to be a part of their holistic management. Part of lipid management, again, is maintenance of weight, making sure lifestyle modifications are adhered to achieve healthy weight. And in our patients who have type 2 diabetes, certainly if they're over 40, between 40 and 75, the guidelines say, irrespective of whether they have had an event before, so they have never had a heart attack, they've never had a stroke, they have no evidence of peripheral arterial disease, and their cholesterol, their LDL levels seem to be within normal range, but we know their risk is pretty high, and we should strive for an LDL of less than 1.8 millimoles for these patients. 1.8 or less should be our target for the patients with type 2 diabetes who are between 40 and 75, irrespective of whether they've had an event before. If individuals are younger and they've had an established atherosclerotic cardiovascular issue, then they should also be on a statin. And if you've increased the statin to the maximally tolerated dose and their LDL is not a target, then there are other agents that can be utilized, and we won't go into many of them, but ezetimibe and the new PCSK9 inhibitor therapies. We want to ensure, though, that in those persons who have established atherosclerotic cardiovascular disease, or they're at very high risk, they've had a stroke, they've had an MI, they have established peripheral arterial disease, we want to go down to 1.4 or less. So just reminding you, we're not looking at the normal ranges for the lab. We want to look at the patient in front of us, and we want to sort of classify them according to a particular risk level, high risk, average risk, low risk, and then we want to target LDLs to fit the patient in front of us. So they've had an MI. We don't want their LDL to come above 1.4 millimoles per liter at all, irrespective of what they'll be pointing out to you on the form to say this is in the normal range. The high intensity statins that we suggest we use in our patients with diabetes are atorvastatin and rosuvastatin, because they're shown to be very effective in lowering the LDL cholesterol by more than 50%. But if you can't achieve that, if you can't go up to the dose that would be required to get their numbers down, as I mentioned, there are other agents like ezetimibe. Not sure we have bempedoic acid available in Jamaica, but the PCSK9 inhibitors are certainly available. So the bottom line is that in cardiovascular disease and risk management in individuals with type 2 diabetes, we want to make sure, yes, that glycemic management is optimal. We want to target particular A1Cs based on the patient profile. We want to ensure that blood pressure management is at the forefront. We want to establish appropriate care for their lipid management. And we also want to use agents in our management of patients with diabetes, which, yes, will help with glycemic control, but also have clear evidence of significant cardiovascular and renal benefits. We spoke about the kidneys, and we know that it is very important to screen patients to assess for the presence of CKD. So yes, the blood test may come back and the eGFR may be optimal, but when you do the urine albumin, microalbumin, or albumin to creatinine ratio, if we're seeing elevated numbers, whether it be micro or macroalbuminuria, we want to make sure that we introduce agents which have been shown to be beneficial in individuals with chronic kidney disease and albuminuria. And the renin angiotensin aldosterone system is very important in promoting changes in the kidneys, which results in deterioration over time. So we want to use agents which can block the effects of the RAS system. We have the angiotensin converting enzyme inhibitors like our prils, lisinopril, perindopril, etc. And we also have our angiotensin receptor blockers, which bypass the side effects of cough sometimes that we see with some of our patients on ACE inhibitors. So try the ACE inhibitors, and there are any issues with lack of tolerability, then ARBs, but sometimes we may go straight to the ARBs as well, because those are proven to be beneficial in our patients with CKD, especially those with albuminuria. For CKD management, we are well aware as well that there are several agents which were initially developed for glycemic control, which were shown to be significantly beneficial in preventing progression of chronic kidney disease and also reversing albuminuria or improving albuminuria, and by extension, reducing cardiovascular risk. And we know these are SGLT2 inhibitors. We use them in individuals with chronic kidney disease plus or minus albuminuria because they're effective in both sets of patients. And certainly we want to ensure that we are aware that once the eGFR is over 20, we can introduce the agents. If you already have the patients on an SGLT2 inhibitor and the eGFR drops below the 20, there's no indication necessarily to discontinue it. In fact, many times there's a slight dip in eGFR shortly after starting the SGLT2 inhibitors, which very often just normalizes after a couple of weeks to months. The non-steroidal mineralocorticoid receptor antagonists, as well with proven benefits, like finerenone, are also indicated in our patients who have type 2 diabetes with CKD and albuminuria, as long as their eGFR is over 25. and their serum potassium is normal, because as you would well imagine, these agents may in fact cause an increase in your serum potassium. So it's very important. So once you've started these drugs, to do your urea and electrolytes, monitor the potassium within 2 weeks of introduction, and keep a close watch on it, because we don't want these patients to be significantly hyperkalemic. This pyramid looks very busy, but it's very simple. It is essentially saying that in patients with diabetes and chronic kidney disease, we want to remind patients that the very foundation of the pyramid is lifestyle adjustment, okay? Lifestyle and self-management adjustments, medications to manage glucose levels, which are also beneficial outside of just getting your A1C to target, that are also beneficial to the kidneys themselves in reducing the progression of, or the onset, in fact, of chronic kidney disease, your RAS blockade, which we spoke about for hypertension, and making sure the statins are on board. And then the GLP-1 receptor agonist, which I'm not deliberately not saying much about, because we have a whole other talk about that, using our antiplatelet therapies for atherosclerotic cardiovascular disease, which we'll speak a little bit more about, our non-steroidal mineralocorticoid receptor antagonists, lipid management, glycemic control, blood pressure control. It all starts with lifestyle, however. We need to beat this home to the patients. The heart failure component. So we've moved to the very end of the spectrum with the CKM, where there's established cardiovascular disease. So in patients with diabetes who have symptomatic heart failure, we recognize that there are specific antihypertensive medications or blood pressure lowering drugs which are definitely indicated. There's a compelling indication for the use of these drugs, because there have been shown to be significant benefits for mortality and morbidity. And these are or ACE inhibitors or ARBs and specific beta blockers, which we tend to use to control the blood pressure, yes, but outside of the blood pressure controlling capabilities, it has further reaching effects on morbidity and mortality outside of just lowering the blood pressure. In individuals who have reduced ejection fraction, and in fact, with less evidence, but yes, evidence there as well for the use in those with preserved ejection fraction, which we're seeing a lot of patients who have type 2 diabetes coming in. They have significant symptoms of heart failure. You send them for an echocardiogram, the EF is 70%. Doesn't mean they don't have heart failure. They have heart failure with a preserved ejection fraction, because a diagnosis of heart failure per se is not done with an echocardiogram. We're taking a history, we're doing the clinical examination, just as we were all taught in medical school. If they're at high risk or have established cardiovascular disease, we want to ensure that SGLT2 inhibitors with proven benefits are utilized. And if they have established CKD, whether it be low eGFR or without albuminuria, then the SGLT2 inhibitors and the non-steroidal mineralocorticoid receptor antagonists, which we spoke about. This basically is a summary of what we've said. Patients with type 2 diabetes, high indicators of high CVD risk, or established atherosclerotic cardiovascular disease, we want to use our GLP-1 receptor agonists or SGLT2 inhibitors with proven benefits. You start one, they're not targeting their A1C, you add the other one. Patients have heart failure, or if the patients have chronic kidney disease, the same applies. SGLT2 inhibitors with proven benefits, and you want to ensure that other things are on board, like your ACE inhibitors, ARBs, and your non-steroidal mineralocorticoid receptor antagonists, and that's not any different. I am hoping I'm still running on time. I'm trying to look at the time, but I'm a little unsure where I am. I think I'm heading up to the 40-minute mark very soon. I saw this from an article published in JACC in 2026, and I liked the picture. It speaks about cardioprotection in the cardio-kidney-metabolic syndrome. And they're particularly alluding to here an eGFR, which is less than 60, individuals with elevated albumin to creatinine ratio more than 30 milligrams per gram, which would suggest at least microalbuminuria, and those individuals with diabetes. And what we're trying to get across to everyone who takes care of patients on the spectrum or with diabetes generally is that prescribing a sulfonylurea and metformin is just not enough for these patients. And we want to make sure we recognize the evidence that is out there and ensure that as much as is possible, we offer the patients what should be offered to them to make their outcome better. So we're using the RAS blockade, we are utilizing our SGLT2 inhibitors. If the individuals have type 2 diabetes and they have persistent albuminuria, despite you're optimizing their doses of RAS inhibitors and SGLT2 inhibitors, we want to add our GLP-1 receptor agonists or our non-steroidal mineralocorticoid receptor antagonists, and not just leave the patients until next year and to come back. We want to recheck their albumin to creatinine ratio every 3 to 6 months to see if there's improvement, and if there's none, then we make adjustments accordingly. We want to utilize our GLP-1 receptor agonist-based therapy or SGLT2 inhibitors in our patients with diabetes or in the CKM spectrum. And again, we're not leaving them till next year to repeat their A1C, but we're keeping them close to us and having them repeat and making sure they have at least some consistency and that they've achieved their target. Otherwise, no clinician inertia should be within 2 feet of us. We should be making adjustments to try to get the patients optimized. Just talking a little bit about antiplatelet therapy. And as we see patients from time to time who come into the office, 45-year-old woman diagnosed with diabetes 2 years ago, hypertension controlled, no cardiovascular symptoms, never had any coronary artery disease, never had a stroke, and they're on aspirin or they're on clopidogrel. The risks outweigh the benefits for primary prevention, but we do suggest or we do advocate for the use of these antiplatelet agents in individuals as secondary prevention. So they have established atherosclerotic cardiovascular disease. Yes, you want to make sure that they're on antiplatelet therapy too as secondary prevention. Benefits outweigh the risks in that regard. I think this is my last or penultimate slide. Very important. And we don't speak a lot about social determinants of health in our setting, but we do know, whether we like to accept it or not, that there are a lot of social factors which affect the development of all of these, not just some, all of these conditions which we've spoken about before, or obesity or diabetes, the hypertension, the heart disease, and the social determinants also affect how well controlled these conditions are. So food insecurity, and by food insecurity, we don't mean having one meal a day necessarily, perhaps having 3-4 meals a day, but what are the components in the meal? Lots of carbohydrates, not so much vegetables or no vegetables, maybe some pasta salad to replace the vegetables and so on. So ensuring that we try to figure out or to identify the patients in whom these social determinants of health factors may play a role in the management, and try to see how best we can harness social services. I know in our setting, social service system might not be as robust, but I think more in the fore of our minds now than the back of our minds, we need to remember that these do play a significant role in management of conditions. It's food insecurity, very important, housing instability, financial strain, and so forth. We want to reduce the risk of complications. It's a multifaceted and multidisciplinary approach. It's not just an individual doctor sitting in their office trying to do everything on their own. We need to make sure we harness the help of others or certified diabetes educators or physiotherapists, just to make sure that the patient is exposed to all the systems that are available out there to try and make things overall better for them. We want to be able to recognize the risk factors by screening for them in our patients when we see them in the office. We want to not just look at the blood pressure for this year and then address the diabetes next year. We want to try to address everything simultaneously. The cumulative effect of addressing everything simultaneously will result in a more significant downstream effect than trying to pick off just one at any particular time. And we want to make sure that we predetermine our targets. Not every patient is going to have the same target necessarily, the same target of blood pressure, the same target of A1C, same weight goal. We want to always make sure that we individualize. So that's why each patient who comes to you is a different patient and you approach in a different manner. So to summarize, and I'm hoping I didn't go off, too far over time, the cardio-kidney metabolic or the cardio-renal-metabolic syndrome ties many risks into a continuum. Adequate screening in our patients with diabetes is very important, and we need to recognize who to screen and when to screen and what screening tools to use. And then the bottom line is that we need to always use evidence-based strategies, which is why these meetings are so important. And I'm looking forward to Dr. Chinharty's talk as well, because evidence-based strategies are very important and need to be employed when we're managing our patients to ensure they have the best possible outcome. And that brings me to the end of my talk.
Awesome. Thank you so much, Dr. Francis Emmanuel. We truly appreciate that exquisitely detailed, informative, and really clear presentation coming from such a complex topic, really looking at that CKM continuum. So, of course, we have a few questions and we want to get into those very shortly. And I know you have a case as well that you want to share with us. So, I'll let you go straight into the case. We do have a few housekeeping matters. So I would want to mention, of course, one, your CME certificates for our audience will be distributed through a post-quiz questionnaire. So we'll share that website link in the chat soon. And thank you to our 366 participants online. We're so happy to have you here. And we're happy that you can join us for Dr. Emmanuel's case. So let's go straight into it.
One moment. Kendra, did you want me to use the cases I had for the pretest, or have the participants already done their pretest quiz?
You can use the pretest ones.
Yes.
Okay, use the pretest quizzes. All right, one moment. Let me just pull up the talk, because I had the quizzes at the very end, or the questions at the very end. All right, so continue to share. Are you seeing the slides now? I think you are.
Yes.
All right, lovely. Okay, so I had a few questions, about 4, but perhaps I won't have time to go through all of them. So we'll just begin by discussing this 56-year-old man who has type 2 diabetes. And he came to your clinic, you did an albumin to creatinine ratio, and you noticed that his EGFR, his albumin levels are elevated. So his microalbuminuria, his number is about 150 milligrams per gram. Anything between 30 and 300 is considered micro. So he has microalbuminuria and type 2 diabetes, and you have managed him on metformin 1 gram twice a day and pioglitazone 30 milligrams once per day. His hemoglobin A1C is 7.6%. And my question is, what is the next best approach to his management? I don't think I can see the comments. No, so I don't know. Oh, let me just have a quick look. All right, let's see what individuals are saying. So somebody said dapagliflozin, one moment, sorry. I'm seeing a lot of people saying dapagliflozin, and somebody said D, which is increase the pioglitazone to 45. And let's see if we have any others. I'm not seeing any A nor C. So, all right. So the individual is 56 years old. They didn't say anything about his body mass index, his blood pressure, and so forth. So we're assuming those are normal. But yes, individuals with type 2 diabetes, very often metformin is a big part of their management. Typically, we start low and we tend to titrate up slowly because some patients may have GI side effects if we start at 1 gram twice a day. I had a patient today came to me about diabetes management, and he never wanted to take metformin again because when he was diagnosed, he was given 1 gram twice a day and he had severe GI side effects. So typically we start slowly and we titrate up. So he's at maximal dose for his metformin. Pioglitazone about 30 milligrams per day. We do tend to use pioglitazone, which also helps with insulin sensitization. May be associated with some weight gain or fluid retention, and the side effect profile tends to be less at the low to intermediate dose of 15 to 30. Going up to 45 sometimes can cause, some side effects like fluid retention and so on, which patients don't take very kindly to. But we're assuming that the ideal A1C for this patient is less than 7%. We're just using that number for now. It could potentially be 6.5, depending on the individual comorbidities. He's highly functional. He has no complications. He has a long life expectancy. Once we can achieve 6.5 or less without any hypoglycemia, then by all means, we're going to go for that. But he's close enough to the 7% target. But the compelling indication for an SGLT2 inhibitor or dapagliflozin, which is what most people said, and that is the correct option in this case, is that he has albuminuria, okay? So a patient who has type 2 diabetes and elevated albumin in the urine or urine excretion, albumin excretion, should be placed on an SGLT2 inhibitor. We repeat the ACR or the microalbumin 3 months time. If he's not at target, we want to maximize the dose to get to the highest tolerable dose. And if that still doesn't get the patients to target, we do have other options, like we have the non-steroidal mineralocorticoid receptor antagonists, and we have ACE inhibitors and ARBs. But adding insulin glargine would not be the first choice here. He's very close to target, and that is not necessarily going to have a direct effect on the albuminuria. It didn't say how significant the albumin levels were, but certainly this is an agent, or other SGLT2 inhibitors like empagliflozin have also been found to have significant benefits where that is concerned. We don't want to continue his current management. His A1C is not at target and he has a complication, so you want to address that. And increasing pioglitazone is not going to address directly the albuminuria, and may actually be associated with more fluid retention and other complications that the patient may not be too happy with. Let me see if there's anything else in the chat that relates to this. All right, great. So most, if not, close to everyone said B, and I totally agree with you. All right, so we have another patient, a 68-year-old man who has type 2 diabetes, comes to hospital with acute chest pain, and he's managed for a myocardial infarction. He's managed and discharged home into your care. The doctor wrote a letter and sent to you and said, continue his management. What is going to be your target for his LDL? Remember, the lab form is going to say the LDL reference range is 2.6 to 3.5. The 68-year-old man with type 2 diabetes who had an MI, what are you going to be targeting as his LDL? All right, somebody said less than, so I'm seeing some C's, but I'm seeing more D's. Seeing some C's, I'm seeing some D's. Lots of C's coming through now, so looks like about equal. All right, So we know it's not, we're not going to say 3.5 millimoles per liter for this patient at all, nor are we going to say 3 millimoles per liter. We know that even though those numbers are sort of within the range, we don't consider those to be adequate LDL-wise in our patients who have type 2 diabetes. So the question is, how are we going to decide now if we are going to aim for less than 1.8 or less than 1.4? In the same patient, 68-year-old man with type 2 diabetes, coming to you for routine care, never had any macrovascular complications of diabetes, we are going to say less than 1.8. But he's had an event. He has had a myocardial infarction. Coming to you for follow-up, one of your jobs, apart from making sure the rest of the things are fine, blood pressure is controlled, the A1C is at target, you want to make sure that his LDL is below 1.3, because this is what the evidence shows or will reduce his risk of recurrent events. Okay. Am I out of time, Kendra?
Not just yet, Doc.
Okay, all right. Let's see if we have any other comments about those two first. All right, so I have 4 in total. I'm moving on to the third now. We have a 48-year-old woman. She has type 2 diabetes, has had it for 5 years and presents for a routine visit. And she tells you that she has had a recent stroke, but her symptoms lasted a day. So she was told she had a mini stroke and she was discharged home after a normal CAT scan of her brain. She was sent home on losartan, metformin, empagliflozin, and rosuvastatin. So she's on an ARB, she's on metformin and SGLT2 inhibitor combination, and she's taking a statin as well. Her blood pressure is 118/65, which sounds good to me. Pulse is 65, or A1C 6.8%, which is around target. We could, as I said, aim for lower if we can achieve that without any particular issues. But is there anything that we should add to this patient's regime? Anything that may reduce her risk of a recurrent stroke? All right, let us see what we have in the comments. We're seeing C, which is aspirin, and I'm seeing a lot of C's coming through. I am not seeing any A's, any B's, any D's. Right, excellent. So we mentioned before patients who have type 2 diabetes and they've had an event, they've had a stroke, they've had an MI, they have peripheral arterial disease, and antiplatelet therapy is a part of what should be prescribed as secondary prevention. If this was a 48-year-old woman, has type 2 diabetes for 5 years, she's never had a complication, she's seeing you and she's on these agents, I would not add aspirin. The only reason aspirin would need to be added is because of the fact that she tells you or she was diagnosed with a recent stroke. It doesn't matter that her CT brain was normal. We don't diagnose stroke necessarily by a CT. The CAT scan is really only done in the acute stage to make sure you don't have a bleed. And her CT scan did not show a bleeding stroke. So it is very important that we initiate the antiplatelet drug to make sure that we reduce our risk of recurrence. She's on all the other things. She's on the SGLT2 inhibitor, she's on appropriate blood pressure control, and she's on a statin. And the final question that I have is a 62-year-old, is that about a 62-year-old woman with type 2 diabetes who came again to you for a review of an abdominal ultrasound which showed that she had liver fat. So she does not drink alcohol, but she's worried about the fact that there is fat in her liver and wants to know how serious it is. Which labs should be ordered to further evaluate the likelihood of fibrosis? Remember, this is not diagnostic, it's just a screening test. What labs are you going to want to request on that lab form so you can work out the score to decide on if you need to send the patient for a fibroscan or GI follow-up? Let us see. We see LFT, we see B, and B is CBC, ALT, and AST. Lots of people saying B. And again, that is definitely the answer. We want to work out our FIB-4 score for our patients who have liver fat, just to see what her what the risk level is for the likelihood of fibrosis. And these are the patients in whom you would want to move on to further gastroenterology review. So you've documented an elevated FIB-4 score, the likelihood of fibrosis is high. Yes, you want to make sure you initiate the usual diet, exercise, trying to lose weight. In some scenarios, we'd say the pioglitazone as well, which we know has its benefits. But if there's evidence of fibrosis, then these patients should really be under the care of a gastroenterologist. And so high FIB-4 score suggests you should refer for assessment as to whether the elastogram will come back saying that they have fibrosis or not. And those patients should really be co-managed, not just by the endocrinologist, the diabetes specialist, or the internist, or the family physician, but some gastroenterology guidance should be present, because as we said, fibrosis begets cirrhosis, begets hepatocellular cancer. We want to make sure that these people are under expert care. These individuals or these patients with this condition are under expert care. I don't have any more questions now, Dr. Kendra. I've run out. So
no problem at all, Dr. Chinharity. Thank you so much for those questions, and the cases that you would have presented to us definitely has helped us to reframe how we're thinking about this continuum that you've mentioned. We do have a question in the chat and a few others. So firstly, some persons might believe that the long-term use of sulfonylureas, it's counterproductive to delaying the disease progression when it's compared to other treatment modalities. What do you think about this line of thinking?
So counterproductive to disease progression. Sulfonylureas are one of the oldest set of drugs that we have available for treating patients with diabetes. And the way they act is by stimulating the beta cells of the pancreas to stimulate or secrete extra insulin. And we have the older ones and we have the newer ones. We have back in the day, they had clopropamide. I don't know if any of the young people here have ever heard of that drug, or they used to call it Dabini. Some of us here may have heard of it before. And the older drugs were the ones that were more long-acting and would stick to the beta cells with more irreversibility. And the complications would be hypoglycemia. A lot of patients would come in with prolonged hypoglycemia. So we've moved away from the longer acting ones to ones now like our glycoside MR, which is one of the more highly developed sulfonylureas, still being used relatively commonly, and which have less side effects or less hypoglycemia as a side effect, less weight gain as a side effect. But as it has to do with and then we also know about the natural history of type 2 diabetes. The longer you've had it, the less effective these agents are, because the beta cells become very fatigued and they're less responsive to the secretagogues. So yes, in the past, we were well aware that these agents, which are highly potent, would flog the beta cells to nothingness almost, and they became not very effective after a while. There are agents out there like liraglutide, some of the injectables, and the pioglitazone, which we know helps to preserve beta cell function. And so in the context of the patient you're seeing, you always have to think about what are you trying to achieve. Side effect profile is very important, looking at it, because in a patient who is at high risk of hypoglycemia, we don't necessarily want to use our sulfonylureas, certainly not the long-acting ones, the ones that are more highly potent and more avidly binding to the beta cells. But you want to make sure that in the symptomatic patient that you use drugs that are very potent. So insulin and the sulfonylureas are very effective in bringing the glucose down very quickly. But you have to bear in mind the hypoglycemic effect, which certainly for people with CKD and so on, you want to watch closely for. So hopefully I addressed the question there.
Awesome. Thank you. Definitely. So one other question would be, you mentioned that Q3 to 6 month measurement of the urinary ACR. So the question now is, what other biomarkers do you recommend in terms of looking at CKD progression?
So the ACR is really recommended as a single yearly test. So once a year, as long as it's normal. But in the patient who is not normal, in the patient who has an elevated microalbumin levels and in whom you are instituting management to address it, you don't want to wait a whole year to see if it's working. So those are the ones you want to repeat the ACR for within 3 to 6 months. And the nephrologists among us will always tell us that there are many other things that you can use to assess for kidney impairment. We always send for blood tests to look at creatinine, urea, and EGFR. But sometimes, depending on muscle bulk and so on, the EGFR that's offered by the lab may not be the most accurate, and sometimes it may overestimate, especially in those frailer patients. Cystatin C is utilized, but it's often not available locally in the labs as far as I'm aware, but can be a send away test. So there are some other renal markers that can be utilized to assess. And again, it depends on what the cause of the chronic kidney disease is, because if you have patients who have lupus nephritis, there are urinary microscopy studies that can be utilized as well to check. I don't know if you have a nephrologist online who will jump in and rescue me here. But statin C is one of them. But for diabetes, though, it's really the albuminuria that we're looking at, because it's one of the markers for sure of diabetic nephropathy.
Awesome. No problem. Thank you so much
You're
for
welcome.
that. And thank you so much for such an amazing presentation,
Thank you, Doc.
amazing cases. And we've now learned, I believe, how to really link cardio, renal, and metabolic health and how we can approach the management.
Thank you. Thank you, Dr. Lee. Appreciate it. Thanks.
All right. And with that, we want to move further into our conversation. I'd like to welcome our second speaker for this evening, Dr. Lisa Chin-Harty. Forgive me if I look down a bit. Both of our presenters have such extensive portfolios. I need a bit of help. But of course, we know Dr. Chin-Harty to be a consultant endocrinologist and diabetologist, and she works at the University of the West Indies Hospital. She's actually had work experience in multiple countries. Within Jamaica, she's worked at the Spanish Town Hospital, within Linstead, St. Jago Health Center, UWI, and outside of Jamaica, she's worked in the Cayman Islands, Canada, and England, of which she completed studies in some of these countries as well. She's also had extensive research experiences with publications, including primary hyperthyroidism versus familial hypocalciuric hypercalcemia. She's also looked at more detailed studies, such as we're looking at the role of prenatal factors in an abstract and postnatal growth on beta cell function and insulin resistance in Afro-Caribbean youth. So, of course, Dr. Chin-Harty would be one of the best persons to take us through our next topic, which looks at novel therapies and how these can help persons that have, again, coming from our first talk, CKM and diabetes in our country. Dr. Chin-Harty, the floor is yours.
Okay, thanks, Dr. Lee, for that kind introduction. I'm gonna start by going ahead and sharing my screen first. Okay. Thank you for asking me to speak about this topic. I'll be talking about semaglutide in practice, particularly in patients with type 2 diabetes. So I know it is close to a lot of us here, getting close to bedtime, so hopefully I can keep us all awake. So I'd like to introduce Marlon, who will take us through this presentation. So Marlon is a patient that we all have in our practice. He is a 50-year-old man who works in a hardware store, and he has been diagnosed with type 2 diabetes for 6 years. He knows about all the lifestyle changes, exercise, dietary recommendations as told to him by his healthcare practitioners. He's on metformin 2 grams for the day, and despite his best efforts, his HbA1c sits at 9.1%, and his weight keeps climbing. He has tried different dietary modifications, but none has really stuck. So he comes to you with his office today. His BMI is calculated to be 34.2, and his blood pressure is going up as well compared to previous visits. So he's asking you if there is something that actually works. So we will draw on our latest knowledge and guideline to properly advise him during this visit. So we're going to use Marlon's case to achieve our objective today, which is to go through the mechanism and formulations of semaglutide in particular. We'll talk about its efficacy and evidence as it regards to glycemic and weight efficacy, cardio-renal protection, which patient is suitable and what the current guidelines are saying. How do we start, titrate, and counsel these patients, and what are the different safety and special situations? So let's start with talking about the background and mechanism of action of our GLP-1s. They've been touted as the latest or the newest drug on the market. But however, the incretin system and the associated drugs have been around a long time. In fact, the incretin concept was first described over 100 years ago. And in 1992, which would be about over 40 years, you had your first GLP-1 like peptide extracted of all places from the venom of the Gila monster. So these substances were first extracted and experimented on really for diabetes control. And then as a good surprise, they found that it caused significant weight loss, and that has now surpassed the current usage. So we'll be focusing on semaglutide in particular. The brand, the first subcutaneous formulation was brought to the market in 2017, and the oral formulation, which was branded Rybelsus, was available in 2019, and it's used for diabetes control. So that's different from the current oral semaglutide called Fundayo, I hope I'm pronouncing it correctly, which is marketed for obesity management. Then you have the higher doses formulation of semaglutide, and now you have your development of smaller molecules and combination peptides, including tirzepatide, which is a combination GIP and GLP-1 agonist. I didn't put the slide here, but currently being developed are hundreds of GLP-1 associated peptides. So there will be many more products that you will see coming in the near future. So what are our GLP-1 agonists? They're based off our incretin physiology. So just to recap, the incretin system is based on our ingestion of meals. So it relies on glucose dependence, insulin release from the pancreas. So what happens when you have a meal? Your GLP-1 is secreted from your L cells in your small intestines and GIP released from your K cells. So they not only stimulate the pancreas to increase insulin secretion, but your GLP-1s will reduce glucagon secretion, which is a counter-regulatory hormone as well. And it has positive effects on beta cell proliferation and survival. We all know about the other effects on the brain, in which it reduces food intake due to increased satiety, but it also has neuroprotective effects. There has even been some trials or hypotheses that these agents can be protective against dementia or slow down the progression of dementia. It has effects on the stomach to cause delayed gastric emptying, and it modifies gastric acid secretion. It acts on the liver to reduce glucose production and decrease hepatic lipid content. They also have an anti-inflammatory effect, also at the level of the heart, and is an anti-remodeling agent. They increase glucose uptake at the level of the skeletal muscle and increase insulin sensitivity. They have effects at the level of the adipose tissue, in which they promote lipolysis, and other anti-inflammatory effects, including specific effects on the suppression of your tumor necrosis factor alpha, your interleukin 1 beta, interleukin 6, and interferon gamma. These agents are also being studied in the use of rheumatological conditions. So our rheumatologists will soon be talking about the indications for these agents. So in natural physiology, our GLP-1 and GIP are broken down by your DPP-4 and excreted. So this is why our DPP-4 inhibitors are also part of our incretin acting agents. They inhibit the enzyme that breaks down or naturally occurring GIP and GLP-1. So for our naturally occurring GIP and GLP-1, these are very short acting agents. They last not more than 1 to 2 hours into the system. So that's a stark contrast from the manufactured GLP-1 and GIP products that we have. So I borrowed this slide from, or a couple of slides from Dr. Ann Peters at the recently concluded ADA conference. And I found it interesting because not just the development of these agents, but the economics of it as well. So exenatide was the first GLP-1 agonist, and that is the Gila monster there. So when it was just brought to the market, it was actually a daily injection, twice daily. So initially there was a bit of a boom, and then it slowly tapered down. And then when they introduced the weekly exenatide, there was another uptick. But then came your later agents now, and you can see the massive increase or massive demand in the market. So the red dotted line would be for tirzepatide, and the blue continue unbroken line would be for semaglutide. So it's quite a massive increase or profit for semaglutide, 163%, but its combination competitor is even higher. In fact, now it is said that tirzepatide is the world's best-selling drug. So what is semaglutide? Semaglutide is a long-acting GLP-1 receptor agonist. So it is very similar in structure to the naturally occurring GLP-1. So over 90% similarity. But what is different is that it has an attached protein chain that makes it longer acting, much longer acting than our naturally occurring GLP-1. The structures of some of the other GLP-1 peptides are there as well. So the mechanism of action is similar to what we went through about the incretin physiology. So the main point is that it has multiple effects. So it doesn't just lower the glucose in the blood, but it has effects on your heart and blood vessels, kidney, stomach, and brain. So these multiple effects are what forms the basis of its current recommendations in the use of type 2 diabetes. So if we are familiar with the 2026 ADA guidelines, there are many different guidelines, but I'm just going to narrow the focus on the ADA guidelines as most are similar. You'll realize that the recommendations are not really for glucose lowering alone, but for organ protection, as Dr. Francis Emmanuel so eloquently explained. Semaglutide is the most extensively studied agent in the class, and it has both an injectable and is currently the only oral GLP-1 option. We'll go through some of the landmark trials specifically, but in summary, some of the benefits, it has a 26% reduction in your major cardiovascular events. It has a demonstrated 24% reduction in major kidney disease events, and you can expect a typical HbA1c reduction of about 1.5% at therapeutic doses. So this is the algorithm for drug treatment or glucose lowering in type 2 diabetes. So if you remember what the previous guidelines showed, they usually start off with HbA1c level and then the recommendation for drug treatments. But as you can see now, you can hardly see any HbA1c level there. What the focus is on end organ protection. So if you look at the algorithm, the amount of times that you see the GLP-1 receptor agonist recommended, if I count on my hands, it's like more than a dozen times. But basically, if you have a patient who have atherosclerotic cardiovascular disease, so these would be your patients who have had a stroke, myocardial infarction, it may be expanded to those with other types of ischemic heart disease. First drug of choice for diabetes control, regardless of their HbA1c, would be your GLP-1 receptor agonist with proven cardiovascular disease benefits. If the patient has high indicators of high cardiovascular disease risk, and we're talking about our patients who are 55 years and older, and they usually have at least two cardiovascular risk factors. And the risk factors we're talking about are obesity, hypertension, dyslipidemia, smoking, albuminuria. You would go for your SGLT2 inhibitors. And then next tier, we would also consider your GLP-1 receptor agonist. Also, first line recommended for GLP-1 receptor for renal protection would be those with your chronic kidney disease. Of course, for weight management, they're very high up on the recommendation as well. Those agents that have the highest efficacy for weight loss would be your semaglutide and your tirzepatide. What is not shown here, which is probably applicable in our setting, is the tier about those with financial constraints. So that tier would be the only one where you would have these agents probably lower down in the options. So if we look at the further detail that the guidelines provide for these agents, or GLP-1 receptor agonist is classed as agents that have very high to high glucose lowering efficacy with no hypoglycemic risk. Their weight loss effect is intermediate to very high, and they have proven benefit for progression of kidney disease, protection against cardiovascular events, and there is also benefits in heart failure. More recent benefits would be in your MASH, previously known as your fatty liver disease. In the algorithm that recommends agents for patients who need injectables, it's no longer recommended to go straight to insulin, but they do say that we should consider a GLP-1 receptor agonist or a dual GIP and GLP-1 receptor agonist first, unless, of course, they are frankly hyperglycemic. In the guidance on management of MASH, or GLP-1 receptor agonists are our first-line treatment, along with the use of pioglitazone. In the chronic kidney disease management, GLP-1 receptor agonist again is part of our first-line therapy. But it would be remiss of me not to mention the economics of these agents, particularly in our setting. So not really to go through this table in detail, but to highlight the cost relative to the other agents that are available. So we know our good old metformin, there's a wholesale price, and I think it's the distributing price. You can see these are in the American setting. So metformin would run the patients just a few dollars, right? Compared to our newer agents or SGLT2 inhibitors that can be quite costly to our patients. So the SGLT2 inhibitors range anywhere from 300 to over 600 US. And if we look at our GLP-1 receptor agonists, cost can be, we can see why cost would be a limiting factor for these agents as well. So that aside, why the push for these agents? So there are numerous trials and data available. I was hard pressed to stick to the time allotted, but I tried to just narrow the focus down to the evidence in type 2 diabetes. So in terms of glycemic control efficacy, or landmark trials would be our sustained trials. So different doses of the semaglutide. So for treatment of diabetes, it ranges from 0.5 milligram to 2 milligrams. And then you have your oral semaglutide. The dosage is a little bit different, but you have the 7 milligram and 14 milligram. So this just highlights that at any dose of semaglutide, you can expect at least a moderate improvement in their HbA1c. And this glucose lowering effect is preserved across all renal function down to an eGFR of 15. In terms of the efficacy with weight loss and other metabolic markers, the mean weight loss that you can expect with the dosages used for type 2 diabetes management is about a 4 to 6 kilogram weight loss. There is a 3 to 5 millimeter mercury fall in your systolic blood pressure, and you can expect a fall in your lipid levels. But these benefits tend to be dose related. So of course, you'll see a greater reduction and greater weight loss at the higher dose of 2 milligrams. So I didn't touch on the higher doses that are available because these are for our weight loss patients. So you have the 2.4 which is not really indicated for type 2 diabetes. For cardiovascular protection, there is a 26% reduction in your major adverse cardiovascular event. So when they quote studies, they'll use the term MACE, and this usually refers to myocardial infarction, stroke, and those persons with ischemic heart disease that needed revascularization or angiography. They are proven to be safe, non-inferior to other agents, and in terms of the oral efficacy, there was a 14% reduction with oral semaglutide. But we're going to more focus on our injectables. The latest trial would be our FLOW trial with regards to kidney protection. So this trial looked at the 1 milligram subcutaneous semaglutide in those already with chronic kidney disease. And this is the first dedicated kidney outcome trial for GLP-1 receptor agonists. And what it did show was that there was a 24% reduction in major kidney disease events, 18% reduction in cardiovascular death, MI or stroke, and an overall 20% reduction in mortality. So that is why when Dr. Francis spoke about renal protection in diabetes, you'll see the GLP-1 receptor agonists are potentially listed as a fourth pillar of CKD, alongside your renin-angiotensin-aldosterone system inhibition, your SGLT2 inhibitors, and your non-steroidal mineralocorticoid receptor agonists. So let's look at the main landmark trials in a little bit more detail. So the main one for the efficacy of semaglutide would be your SUSTAIN set of trials. So these were what you call phase 3 trials. So these were the trials done on the drug before it was brought to the market to be used widely in patients. So they have numbers 1 to 10, and there's a SUSTAIN 11 trial as well. So it was quite extensively studied. So the first SUSTAIN trial looked at those diabetic patients that were being managed with diet. So they've never been on any pharmacotherapy. So semaglutide would have been the first agent used. And then the other trials looked at the comparison with the different pharmacotherapy agents available. So they had compared, there was a study that compared semaglutide to a DPP-4 inhibitor, sitagliptin. There was a trial comparing the use of semaglutide with once weekly exenatide, so another GLP-1 receptor agonist, as well as against dulaglutide. There was a trial that looked at the benefit of using semaglutide versus basal insulin. There was one comparing SGLT2 inhibitors, both as a substitute and as an add-on. There was a trial that looked at the use compared to liraglutide as well. And we had our cardiovascular outcome trial, which was a SUSTAIN 6. So in summary, what they all did show, so if you look at this bar chart, the different bars will correspond to the different doses of semaglutide. So our light blue bar is the lowest dose, which is 0.5 milligram, dark blue, 1 milligram. This was before they extended the dose to 2 milligram. The other colors will correspond to the different agents that they compared it to. And as you can see, both doses of the 0.5 and 1 milligram semaglutide resulted in a greater percentage reduction in the patient's HbA1c across all the trials. In terms of the patients that were able to achieve a HbA1c target of less than 7%, we can also see that both the 0.5 milligram and the 1 milligram had a greater proportion of patients achieving this target. And if we look at the change in baseline from body weight, both the 0.5 milligram and 1 milligram, more greatly seen with the 1 milligram, showed a greater reduction in our body weight. In terms of exactly what percentage of body weight, because we do know that we encourage these patients to have at least a 5% body weight loss to achieve any sustainable metabolic effects or improvements from their diabetes. Both the 0.5 and 1 milligram had greater patients achieving more than 5% weight loss, greater with the 1 milligram semaglutide. This shows a similar benefit. This compared those patients according to the number of years of diabetes. So whether they were newly diagnosed or had long-standing diabetes, the glucose lowering effect or HbA1c lowering effect was still present. They also looked at the change in body weight by diabetes duration. Again, benefits was still there regardless of whether they were newly diagnosed or had diabetes, long-standing diabetes for more than 10 years. They had done comparisons also according to the percentage weight loss according to the duration of diabetes. So at the 1 milligram dose of semaglutide, you had similar percentage patients achieving both a 5% reduction and a 10% reduction in body weight across all duration of diabetes, whether newly diagnosed or long-standing. The percentages achieved were similar. In terms of adverse effects now, the most common adverse effects that were reported would be our gastrointestinal adverse effects. So as much as 45%, regardless of the duration of diabetes, a larger percent with the higher dose of semaglutide. Other than that, other adverse effects that were reported were relatively uncommon. So is there a link between the incidence or the occurrence of nausea and vomiting, which is the most common adverse gastrointestinal effect, with the amount of weight loss associated? So the studies showed that there actually wasn't that much difference in the incidence of nausea and vomiting. These were more dose related. And they were not sustained. They were quite short-lived and tend to happen at the beginning of therapy. So some of the summary points from the earlier trial findings of the different sustained trials. So does the efficacy of semaglutide differ across people with different disease duration? So the answer is no. Semaglutide consistently reduced HbA1c and body weight regardless of diabetes duration. And is the effect of semaglutide on weight loss mediated by nausea or vomiting? And that says no, there was still superior weight loss due to direct effects of semaglutide, and it wasn't directly related to nausea or vomiting. I highlighted the SUSTAIN-9 trial, which was one of the latter trials, which still showed benefit with your 1 milligram semaglutide with a degree of HbA1c reduction, as well as significant reduction in your body weight. If we jump to the adverse events, similar findings to the previous trials. Most common adverse effects would be the GI side effects. For the cardiovascular outcome would be our SUSTAIN-6 trial. So this was the only one that looked at the cardiovascular benefit. So they looked at same 0.5 and 1 milligram semaglutide, but these would be patients that are 50 years old and older, and they had established cardiovascular disease, and they didn't necessarily have to be on any anti-diabetic treatment. Some were not on any, and then some were on maybe 1 or 2, including basal or mixed or pre-mixed insulin. So in terms of the outcome, so this is the time to first occurrence of cardiovascular death, non-fatal MI or non-fatal stroke. The incidence was less for semaglutide. The difference is more marked with the longer duration of treatment. So if we look at the post-hoc analysis or the meta-analysis, most of our cardiovascular endpoints would favor the use of semaglutide. What came out in this study as well was the question on microvascular benefits or benefits with regard to or complications. So it was significant to show that there was no new or worsening nephropathy on those with treatment with semaglutide, and that there was actually a slight increase in our diabetic retinopathy complications. What this is highlighting is there was some concern when these agents came out about whether or not they actually do worsen diabetic nephropathy. Diabetic retinopathy, as the previous trials didn't really have patients with established retinopathy, and those didn't show any significant increase. However, this trial that had looked at cardiovascular benefits, they did have some cohort of patients that already had established diabetic retinopathy, and what they found was that there was increased occurrence of worsening retinopathy in those already with established retinopathy. So the guidance is that these patients should be classified as stable or be undergoing treatment with their ophthalmologist prior to starting any GLP-1 receptor agonist therapy. It's more due to less of a direct effect from these agents, but rather due to an effect of rapid glucose lowering or rapid diabetes control, because we see similar effects with our SGLT2 inhibitors, particularly if the patients undergo rapid lowering of their glucose level. They can have worsening of pre-existing retinopathy. So now the main thing for this trial was, is there MACE risk reduction with semaglutide? And they said that the MACE risk reduction was greater with semaglutide than placebo, regardless of the patient's baseline cardiovascular risk. So this slide is showing similar to what I was saying about worsening diabetic retinopathy. So if you look at the patients without a history of diabetic retinopathy, there was no significant increase in this complication or worsening. Now we take a look at the SUSTAIN 4 trial in particular, because this is when they looked at whether a higher dose of semaglutide, which is a 2 milligram, is effective. So this was particularly born of the fact that you do have some patients that are on the 1 milligram dosage that still did not reach an HbA1c target of less than 7%. So when they compare the 1 milligram to the 2 milligram, essentially do see further lowering of their HbA1c. So the average HbA1c of those with the 1 milligram was 6.9%, and the 2 milligram achieved greater, a lower HbA1c on average 6.7%. So these would be patients who started off with a HbA1c of 8 to 9%. So while the change or the improvement might seem small, remember, even a small reduction of your HbA1c causes a significant reduction in your complication risk. The weight loss effect was also greater with your 2 milligram. They change from baseline in terms of their weight. So 1 milligram semaglutide, the patient's baseline weight changed from 99.3 kilogram to 93.3 kilogram, compared to the 2 milligram, where it went down to on average 92.4 kilogram. And if we notice that the time that this benefit was seen here, it's at 40 weeks. So this would be 10 months. So this would be important later when we counsel our patients about the use of these drugs and what their expectations should be. This is looking at the adverse effects with the higher dose of semaglutide, 2 milligram, which showed no significant increase. So it did achieve a greater reduction in their HbA1c along with weight loss without any significant increase in adverse events or side effects. I put one slide for one particular adverse effect in particular that wasn't mentioned in the previous trials analysis, and this is with regard to loss of lean body mass or muscle mass in particular. So this was a meta-analysis done on several GLP-1 receptor agonists, including the combination GLP-1 receptor agonist and GIP, and they all cause some degree of reduction in lean body mass. So if you look at the bottom of the slide, when it's to the left of the vertical line, that indicates loss of lean mass, versus B diagram, its comparison with the amount of fat mass lost, and the A diagram shows you the total body weight that was lost. So remember, so both the fat mass body weight loss will be greater with the higher doses of your GLP-1 receptor agonist. But we do need to also remember that with any amount of weight loss, no matter the methods in which the weight loss happens, that we don't only lose fat mass, but we lose about 20% lean body mass or muscle mass. So then it would track that the more weight that is lost would result in more loss in muscle mass, regardless of the method that is used. That being said, there are several options to mitigate this loss, including, as Dr. Francis previously mentioned, strength training, and there are several pharmacological agents that have been developed as well. So we had spoke briefly about the flow trial with regard to renal outcome. Just to highlight the patient criteria that they used. So these were adults who had type 2 diabetes with an A1C of 10% or less. They were on a RAS inhibitor, and they divided them up into those with the eGFR of 50 to 75 with a urine albumin to creatinine ratio of greater than 300 but less than 5,000. And then those with your eGFR between 25 and 50 and urine albumin to creatinine ratio of greater than 100 to less than 5,000. So they compared the addition of semaglutide to standard of care, and what it showed was a 24% relative risk reduction overall. When it came to all-cause death, there was a 20% relative risk reduction. So this being said, now we have combined all this data that we knew. We explained it to Marlon, and we told him what the evidence promised. So with regard to Marlon, it promises that his HbA1c will fall from 9.1% to about 6.7%. It promises him that his weight will fall between 10 to 15%. So while 10 to 15% might sound a little bit high when you calculate it for Marlon, so that is about a 9 to 13 kilogram weight loss, which is about 20 pound to little under 30 pound weight loss for him. And you can promise him that he will have a reduction in his cardiovascular and renal risk. So I don't know if he's looking at you in disbelief or if he's balking at the price of the agent. So in terms of patient selection and prescribing now, so we mentioned it is approved for any adult with type 2 diabetes as an adjunct. Very important, the diet and exercise. Nothing replaces diet and exercise. It's commonly added to or alongside metformin, and we consider semaglutide when glycemic weight and cardio-renal goals are not being met. So particularly favored if the patient has established atherosclerotic cardiovascular disease, is at high cardiovascular risk, if they have CKD, if they're overweight or obese, and they have weight loss as a target treatment for their diabetes. If there is a need to avoid hypoglycemia or weight gain, and of course they have the oral therapy as an option for those who don't like injections. So the two main formulations that we have are subcutaneous and oral. So the subcutaneous is given once weekly, and it's given in a stepwise dose. So you start with 0.25 milligram, stepping up to 0.5 to a maximum of 2 milligrams per week. It's given any time of day with or without food. For oral agents now, what I found when I was prescribing it for the patients in the UK is that it was very poorly tolerated. The GI side effects were quite significant. So most of the patients ended up switching over to the subcutaneous formulation, but it did have its place. So in terms of what's available on the market, you will hear a lot about the terms about compounded versus generic formulations. So when we talk about compounded products, these are not the same as our generic products. Compounded now, basically if a drug is placed on a drug shortage list, the molecular structure is given to several approved pharmacies that can then make these agents. They're custom mixed, they're non-FDA approved, so they're not under as tight regulation. They tend to be cheaper, more accessible, but then you have the greater risk of contamination, inaccurate dosing, lack of regulation, right? For generic drugs, for the most part, I'll say for the most part, are FDA approved, and FDA means it's a US regulatory body. So remember, you have different countries with their different regulatory bodies as well. These are mass produced and they're identical to the brand name drugs in terms of the quality, strength, and efficacy. So that being said, so the patent for semaglutide was up earlier this year in your non-US countries, but the US patent for semaglutide is still in effect till 2032. So whenever you see a generic, you will actually say that it is FDA approved really because of this. So what do we have available locally? So technically, they're not available on the market as yet. It's commonly used, but it is actually not formally on the approved list from the ministry as yet. So what you'll see available tends more to be the compounded products. So the compounded products tend to come in vials as a powder that needs to be mixed. And the additives to these products will vary. But some of the common additives can include B12, L-carnitine, and vitamin B6 are some of the more common additives that I've seen. And then, of course, you have the branded products, which tend to be in pens. But then now you also have your counterfeit products. In fact, FDA had an article a couple months ago in which they found fake products on their markets. And as you can see, the fake products tend to look very similar to the branded products unless you know what you're actually looking for. So before you prescribe these products, you must know the contraindications and cautions to know if your patient is go ahead to start this. So absolutely contraindicated would be patients with a personal or family history of medullary thyroid carcinoma. This has really only been demonstrated in rodents. They're not quite sure the human relevance, but it is a contraindication out of caution. Anybody with a history of MEN2 syndrome, or if they've had prior serious hypersensitivity reaction to semaglutide. You should use them in caution in patients with a history of pancreatitis. If they have gastroparesis or other severe GI disease, the reduced gastric motility that you see with semaglutide tends to be short-lived, but if they already have underlying gastroparesis or other GI pathology that can reduce their gut motility, this effect might be a little bit more prolonged. If they have advanced proliferative diabetic retinopathy, if they are at risk of dehydration, as they can develop acute kidney injury if they do have significant GI losses. If it's combined with insulin or a sulfonylurea, there's a high risk of hypoglycemia. So what I usually do, depending on what their glycemic control is, I will preemptively reduce their dosages by about 20%. It's not, the safety is unknown in breastfeeding. It's not recommended in pregnancy, and usually preconception counseling is advised for our patients. Well, for any patients with diabetes, preconception counseling is necessary. But if they're on GLP-1 receptor agonists, we usually discontinue a month or two before attempting. So what is involved in the baseline assessment and counseling of the patients? So you want to confirm that these patients have type 2 diabetes, although there are ongoing trials that are looking at the use of GLP-1 receptor agonists in our type 1 patients. particularly those who are overweight or obese. You want to screen them carefully for MEN2 or history of medullary thyroid carcinoma, pancreatitis. You want to do a baseline weight, blood pressure, HbA1c, and renal function. And I would broaden it to include other markers such as the waist to hip circumference, because we do know that just weight and or BMI is not adequate for evaluation of clinical obesity. Reduce their hypoglycemic agents if used. You want to check their pregnancy status first and ensure that they have a proper contraception plan. I would also add nutritional history, a detailed dietary recall. This is very important, not just at the beginning, but as ongoing monitoring of these patients as well. Although you're using it for control of the type 2 diabetes, as their intake is gonna change, you want to make sure that their nutritional status is adequate and they don't develop any vitamin or mineral deficiencies, and you can recommend replacement as required. Setting your expectations are very important. Oftentimes when you mention these agents, both patient and provider alike, the common misconception is that the patient will go from a diabetic patient to a non-diabetic patient, or the patient will move from a size 20 to a size 1 overnight. Or that it replaces the recommended physical activity and exercise and adjustments to nutrition, none of which are true. You want to counsel them about the GI effects and how to manage as well. And you do need to titrate slowly. So you should not rush the dose steps, even if you think you are not getting good effect as yet. So every 4 weeks is when you step up the dose as needed. Most patients are maintained at a dosage of 0.5 to 1 milligram. So you will be guided initially by what their glucose control is like, whether it be home GMR monitoring or if they have a continuous glucose monitor. When you are at week 9, then you can check their HbA1c to see if there is any improvement and intensify as necessary. So how do you manage the side effects and the risk? Okay, so common side effects, nausea and vomiting. What has helped? Titrating the dose slowly, eating small, low-fat, low-volume foods. They'll tell you that they tend to be more nauseous when they have high-fat foods like fast food and or common fast food meals. Also, some persons say that dairy aggravates their GI effects as well. And important to know that not only diarrhea, but in fact, constipation tends to be a more common side effect than diarrhea. So they need to maintain hydration as well, and they need some reassurance that symptoms will typically resolve with time. I would advise good reminders, maybe something physical like a handout, rather than just verbal counseling. This is a good one in the mnemonic meal. So you want to emphasize that they should maintain their muscle with adequate protein intake along with the requisite physical activity and exercise, which should be at least 2 to 3 days of strength training for at least 30 minutes. The typical diabetic plate that we counsel our patients to have, which should consist of mostly vegetable, non-starchy vegetables. So that being said, the main goal is to prevent muscle mass if they do have significant weight loss with these agents as we achieve their diabetes control. So you do have some patients that, despite the requisite strength training and protein intake, still have muscle loss. Patients who are particularly at risk of this would be our elderly patients and those patients with frailty. So we have several agents that are in the pipeline that are being developed. Very long, difficult to pronounce names, but you can take a quick note of these different pathways and agents, and you will probably hear more of them at a later date as the trials show, if the trials show any great benefit. So what are some of the special considerations? So in our patients with renal impairment, no dose adjustment is needed. We mentioned the consideration for pregnancy and lactation already. If the patient has liver impairment, no adjustment is required. And the delayed gastric emptying may alter some other absorption of drugs. So you should be mindful of this. One particular area of concern would be possible risk of aspiration if they have to undergo any procedure that requires anesthesia, including endoscopies. So the more conservative approach is that you hold the GLP-1 receptor agonist for at least a week before these procedures. And then some may even advocate for a gastric ultrasound or to manage these patients as having a full stomach if the agents weren't held. This was more the conservative guideline 2023. In 2024, the anesthesiologists agreed that most patients may continue these agents, but you discuss with your anesthetist to determine what is the risk of aspiration and if it is best to hold these agents or not. The endoscopists do prefer when these agents are held though. So I just added this slide just to let you know the ever-changing landscape for these agents. So within the last year, although most of these indications didn't really fit with the subcutaneous semaglutide. As you can see, the indication for moderate to advanced liver fibrosis in MASH for was approved August last year. And then you have tirzepatide, which is now approved for children and adolescents 10 to 17 years with type 2 diabetes. So let's go back to Marlon now. He is 6 months in on his treatment. His HbA1c is now, his diabetes wasn't cured. He didn't move to a size 1, but he did have very good benefit. His HbA1c went down to 6.6%. He had about a 23-pound weight loss. And his BMI, although technically still obese, it has improved from 34 to 30, and his blood pressure went down from 142/88 to 128/80. So in summary, semaglutide does deliver a substantial HbA1c reduction with low intrinsic risk of hypoglycemia. It provides clinically meaningful weight loss and proven cardiovascular and renal protection in your high-risk type 2 diabetic patients. Remember, it's indicated in our type 2 diabetic patients with atherosclerotic cardiovascular disease, CKD, and obesity, regardless of their HbA1c level. And the key is to start low and titrate slowly. GI effects are common, but usually transient and manageable. Our patients do need adequate counseling on diet, strength training, and then you need to be evaluated for other serious potential adverse effects in the future. And that would be the end of my presentation. Just looking at the time, and I did go way over time, so I'm sorry for that.
We're so happy to have you with us still. No worries, Dr. Chinharty. So thank you so much for such a wonderful discussion, really, on the GLP-1 therapy, semaglutide. And we really hope that coming from this, we can actually initiate in practice, helping a lot of our patients with CKM in future and diabetes. One question for you would really be so much so in terms of accessibility, because you did start out by mentioning that, of course. What do you think could help some of the patients in our region to get better access to these therapies? Or what do you think would assist even physicians in knowing how to initiate or how to identify support for patients?
Okay, for greater accessibility for patients, well, it would be better knowledge overall, both on the side of the healthcare providers and the patients, so that greater advocacy can be had to get these agents readily available and subsidized, whether it be from the national program and including or insurance companies as well. I think the focus is more towards the other benefits rather than the true benefit to our diabetic patients. So yes, I think that is the main thing, and development of similar products that are more cost effective and available.
Awesome. Thanks so much for that answer. We really do appreciate your time this evening and the discussion that you'd have put forward to us tonight. So for sure,
Thank you.
we want to close off by a few more points. Thank you to our 350 plus participants still online with us tonight. We're so happy that you could join us. So just to let you know, in regards to your CME certificates, we will be issuing an email regarding a link where you can join, answer the MCQ questions, and then your CME will be generated automatically. With that said, we do have one more video that we'd want to share with you, just to tie into the night, and then a last survey. So please stay with us. And Sam, I'll invite you to share our last video and our survey.
Type 2 diabetes and obesity are deeply connected. Yet they continue to be treated in isolation, and the consequences are growing. In Jamaica, the challenge is already here. 3 in 4 patients with type 2 diabetes remain uncontrolled. 86% live with overweight or obesity, and for many, weight is still not recognized as a contributor. But diabetes is not just a comorbidity. It is a cardio-renal-metabolic risk, impacting multiple organs silently, limiting the true potential of Jamaicans. When the problem is this connected, the solution must be too. Therefore, let's help our patients break free from the burden of diabetes and live their full potential. Because good health can't wait. This is where Dr. Reddy's steps forward with a legacy of innovation and a commitment to access and affordability. And today that commitment goes further. What if managing diabetes could do more? Not just controlling glucose, but transforming health. Helping Jamaicans move closer to better health outcomes. Because diabetes needs more than control. It needs a new perspective. It's time to rethink diabetes. And that rethink begins now.
On behalf of the Dr. Reddy's team, we thank you for joining us tonight. Thank you to our speakers, Dr. Patrice Francis Emmanuel, Dr. Lisa Chinharty. Thank you to you, our audience. You've stayed with us. Thank you to our technical team, and thank you so much to our internal teams that have made this webinar possible. We look forward to seeing you in the next one, and stay tuned for our last survey as we want to improve how we impact your webinars in the future. Good night.